Thank you, everybody, for coming. And thanks so much, Josh and Ben, for some really interesting conversation. Now, for something quite different. You see my title, which actually changed just last week. Um, I added the beginning, the quote from Abraham Lincoln from the Gettysburg Address, just to remind all of us that, our government is and should be of the people, by the people, and for the people. Good thing to remember today. So I always like starting off with a case. Mr. W, 54-year-old at the time, who started in center hemodialysis basically when a new facility medical director was hired. Fast forward 16 years later, and he was the only remaining patient at the facility. Some people had been transplanted, most had passed away just as the medical director's leaving for a new position. And he made some comments that really stuck with that facility medical director, just commenting, wow, this is one of the biggest changes I've seen in this facility in 16 years. And, am I going to die without anything else changing? So, with that prelude, just want to remind all of us that when I started in my fellowship, I was in fellowship in 2000. This is close to what a facility looked like and doesn't look that different today. And hopefully in 2050, it won't look like this. We know that other areas of technology and science really have advanced through the ages. And so we need to make the case for our patients. And, why does everything look so similar? So, if you're getting into an elevator with a member of Congress, you want to be able to say in less than 60 seconds, what the Medicare ESRD benefit is and why there's a problem that, yeah, it covers kidney transplant and dialysis, but it's currently a bundled system, one payment for everything. And really, to get new therapies, drugs, technologies into our patients, investments critical. Investors, innovators, they're not going to, they expect to recoup on their investments. And, this is a rhetorical question. Are they going to invest in areas that are less likely or more likely to result in return? So, more about other payment systems later. We've got another 25 minutes to talk, not just the 60 seconds. So, I do want us to understand the ESRD benefit first, that some people have both said is a blessing and a curse, given that it's there for our patients, but doesn't allow for a lot of movement forward. And I thought that it would be helpful to understand how we actually get this funding, particularly timely. I thought, given that we are on day 3 of a government shutdown. So, by way of overview for our next 25 minutes, I do want to talk about understanding government funding allocation, especially with regards to healthcare, outline the benefit, talk about why our patients need system change, describe some of the steps that are being taken for ESRD payment system overhaul, short and long term, and really emphasize what we need to do or is being done in terms of advocacy to make our government work better, not just for people with kidney diseases, but all of those who surround them. So, understanding government funding allocation. Last fiscal year, we were at about $6.8 trillion. It's a little over that as we're just finishing up calculations for FY25. I think it's important to remember that there is not just discretionary funding, but mandatory funding too. And the mandatory funding is almost 2/3 of the spending. And just under half of that is spent on mandatory entitlements, including Medicare, Medicaid, and the Affordable Care Act. Discretionary, it's a little over a quarter. Don't forget, though, that there's a huge slice to fund government debt. And that is growing, of course. So when we take a look into mandatory spending, this is mandated by law. Whatever authorizing laws have been passed, the money must be allocated for these each year. That is the Medicare, Medicaid, Affordable Care Act. And there's no arguing across the aisle about this. Some of you might be saying, but hey, there's less funding going out, for example, for Medicaid this year. So what happened to that mandatory funding? Well, if you've passed laws that then impact your appropriations, that's how you can make a change. So we know that HR 1 passed in July, One Big Beautiful Bill Act, which I will now call OB3 for the rest of this talk. Did change Medicaid funding, and that's what's newly mandated. And so, again, for mandatory funding, the first step, those laws are requiring money to be spent. Secondly, the Treasury issues those funds to all of the appropriate people that hold contracts, direct payments, other assistance. And then the last step is that the entitlement program benefits are paid out to the people, the businesses, and the governments, both state, locally, etc. When we think about mandatory health insurance spending, as I mentioned, it's just under half of our mandatory funding, and that has expanded over the last decades. We're talking about, 1.7 trillion from last year. And you can see the breakdown in terms of Medicare, the number of people, Medicaid, the number of people, and dollars, and the Affordable Care Act markets. And this is actually one of the reasons that the government is shut down right now because Democrats and Republicans are arguing over the extending the Affordable Care Act tax credit. So good for us to know that. Also, for the purposes of this talk, dialysis care uses a disproportionate number of dollars per person. So, approximately 80% of dialysis patients are actually covered by the Medicare benefit, either fee-for-service or Medicare Advantage. And, it's less than 1% of all Medicare patients that actually utilize somewhere on the order of 6 to 7% of funds. They're really expensive patients. Um, so let's just move on quickly to talk about the discretionary spending and the other slices. This is spending that's not mandated by law. It's formally approved by Congress and the president. This happens during the appropriations process. About half of this discretionary spending is for defense and then all the other agencies as well listed here. It's important to remember that this is supposed to start well ahead of when the fiscal year starts, which was supposed to be well, it was October 1st. By February, the president's actually supposed to submit recommendations. Most of the time, everyone in Congress ignores the president's submitted budget and moves on to the House and the Senate proposals. But this year, they actually did look closely and they tried to incorporate a lot of the presidential requests into their budget. So Congress reviews and revises, votes during the whole appropriations process. Usually that finishes by the summer, and of course that has not finished. And then the president signs the budget into law once the House and the Senate have voted and agreed on a budget. And we are right in the middle of all of that right now. And then the last of the three pieces of the pie that I showed earlier is that US debt, and that is growing. And, in 24, it was 35 trillion plus dollars. I just looked it up this morning, over $37 million, and about 13% of the federal budget. You can see how it has substantially increased over the last 20 years. So this is what we just talked about. And moving on from how the government spends its money and thinking about the Medicare entitlement, Medicare was a new entitlement in 65, signed into law, you can see by Johnson. And thinking about how dialysis has evolved, even before Medicare was a new benefit, we know that chronic dialysis began in 1960. You can see Belding Scribner and Clyde Shields in that iconic picture that we all know and love. And then this panel was one of the panels that decided who was able to give out spots for people to actually get long-term dialysis. Very famous picture from 1962. So, what Medicare was for those greater than 65 at this time. But what about those who were disabled? I'm not just talking about dialysis patients, but all people who were disabled. So between 65 and 72, this was debated very extensively. A lot of words on this page, but the bottom line is that it took an act of Congress to get those who were disabled covered. It was a 1,300-page amendment to Social Security. But this was the entirety, two different paragraphs basically on the right side of this screen. That is the Medicare ESRD benefit. Specifically, every individual who has chronic renal disease and who requires hemodialysis or renal transplantation for such disease, including the spouses or dependents of those who would qualify for the entitlement. So, introduced in the 60s, became a benefit in 73, and we're still puzzling to try to figure out how to provide high quality care at a low cost, given that the taxpayer does cover a lot of this bill. Um, so, yeah, 73, but things evolved since 73, right? Past in 72, started in summer of 73, lots of updates, and starting in 83, it became a partially bundled payment because they didn't want to keep piecemeal paying for something that was so expensive. Recognizing that it continued to be expensive, Congress passed more laws. And really, it was the MIPA, Medicare Improvements for Patients and Providers Act in 2008, that legislated how the current Medicare benefit exists. It was supposed to curb expenditures because it was recognized that costs were out of control at that time. EPO, erythropoietin, was being used extensively, probably to too great of a degree, and resulting in a lot of profit to providers. And this was not just going to be a single payment for all dialysis care except for physician payment, but it was also going to be linked to quality measures to make sure that if you give a bundle of payment, you're not giving low quality care. And so this bundle that started in 2011 is based on 2008 principles in healthcare. This bundle was pretty successful. We actually saw that it accomplished the two things that they wanted to happen. A decrease in erythropoietin use, very successful. And they also talked about increasing home dialysis, which we know between the time of like when we knew that this legislation was calling for increased rates of home, um, and then, it did improve. And think about this. Back in '08, the incident prevalent rates of home hemo and peritoneal dialysis were quite low. You're talking less than 7% of all of the population. We're still on the low side, I feel, but certainly at higher rates. So, with all of this, with the reality here, how have we done since 2011, 2012? Well, yeah, there's some very small trends in improving survival over the course of 7, 8 years up until the pandemic, but they've really largely stagnated, especially if you compare this to other states of disease with advanced disease states. The bump up in particular for 2020 and 2021 is very reflective of the pandemic, just FYI. And this is in the context of, a growing number of people with end-stage kidney disease. So we really need to do better. So this 2008 healthcare is not really made for 2025 and certainly not for 2050. We've got this bundled payment system covering all kinds of things, related drugs, the dialysis services, the nursing staff, the infrastructure, all of the capital costs, some laboratory tests, and really it's not covering innovation. It's aimed to incentivize efficiency and quality. And the base rate that you get is adjusted for a few things, like you get paid more in Seattle than you do get in Puerto Rico, for example. But still, it doesn't quite cover costs. And if you look at the reports from the Medicare Payment Advisory Committee, MedPAC, we know that in the smaller dialysis organizations, the non-for-profits, we're either barely making breaking even or are actually getting paid less than we're spending to provide care on the Medicare side. So, we need incremental change at minimum. And so, how do we do that? So, when we recognize that there's a disincentive for innovation, Medicare actually did note this again and again from the Payment Advisory Committee perspective from the 2012 period up until 2016 and 17. So they did add on some payments for innovative drug therapies and the potential to attract innovative technologies. The drug add-on payment, I'm not going to read through all of this given the time, but the bottom line is it started, but it only paid a certain amount temporarily. And then they bundle it in, and it's really, again, not served as an incentive to try to increase innovation and improvement in the care for our patients the way we've seen in other fields. And in terms of technology, there was a transitional add-on payment added that started in 2020 for new equipment that was supposed to be innovative. Well, I'll tell you, only one of all the people that have applied has actually qualified for this added payment. It's paid for 2 years at a small amount, basically at depreciating costs of the capital equipment, and then thereafter nothing is added. So again, these two mechanisms that were supposed to be helping out have not actually helped to attract innovation dollars. So, with this stifled innovation, how can we improve access? And I'm just listing some of the new things that are out there. There have been drugs that do help patients, but they haven't been used or adopted to the extent that would probably benefit our patients. And some of the technologies that have applied, for example, higher cutoff dialyzers, didn't even meet criteria. So there we are with our 2025 dialysis. In comparison, contrast other fields, cardiology and oncology. And as I was preparing this talk, I'm not going to talk through this whole next slide. It was really jaw-dropping for me to see the state of the art for oncology. And really, I tried to dig in from 2000 to 2025. This is just a small list of high-level categories of targeted drug approvals, immunotherapies, diagnostics, procedures, just incredible categories of things that have really impacted not just mortality, but also quality of life for patients. There's all kinds of things right now on the horizon to refine therapies, new diagnostics, cellular therapies, improved access. And, people are predicting for 2050 that there's going to be personalized prevention, cancer vaccines, advanced delivery methods that we haven't even thought about yet. And, why is this? Well, things are paid for very differently. And again, I'm not, for the nature of time, I'm happy to have conversations about all of you about the differences in how things are paid for. But the bottom line is this attracts investment. So we really need not just incremental, but I would say disruptive change for 2050. So how do we think about this? So I did mention we'd love to have both short-term and long-term, not good to just think about one or the other. So what are some immediate opportunities for policy improvement? So we could refine the adjustments to the base rate for dialysis. That would be great. Strengthening the quality of care for things that actually matter to our patients in terms of our quality metrics. We can make sure we're thinking about and addressing differences between populations, which means we have to be able to gather data. I will say we took a big step backward in terms of the form that is the intake form for all of our patients. This year, they grayed out the areas where you can enter race and ethnicity. So we can't even look at differences in our patient populations from this year's data. And there's a lot of bell clanging about that, including in front of HHS members. So more to come on that. ASN just put out a large statement, and we've actually got the attention of people to try to change this back. Enhancing transparency and thinking about stakeholder engagement. And then, short-term innovation, not, including the drugs and technology, but this really requires long-term change. So just thinking about this A through E, refining base rate and adjusters, I've kind of gone through this, but the bottom line is we need better adjustment for patient comorbidities and disease severities and making sure we're actually updating the geographic cost indices that are appropriate. More about how to actually do that in a sec. Strengthening the true quality of care, as I mentioned, incorporating better quality metrics like patient-reported outcome measures that are accurate, getting us a patient survey in the home environment. And people here, thank you, Dr. Rivera and Dr. Mahutra and others, are actually working on some of these as we speak to try to get this incorporated. And Medicare on the regulatory side is paying attention and thinking about this possibly in the next 1 to 2 years. Um, Promoting the differences I mentioned already about collecting data that is not being collected right now that needs to be collected and thinking about more data that needs to be collected so we can understand what payment adjustments and incentives can support better care delivery to all communities. In particular, like social determinants of health, which really do make a difference. And then transparency and engagement, there's a lack of clarity and limited opportunities for stakeholder input. And Medicare recognizes this. They're trying to get better patient input and more regular dialogue. And then the E of this A through E, I mentioned about TDAPA and TIPNIs bringing in innovation dollars for drugs and technologies. Well, let me tell you, this is really just a Band-Aid for a gaping wound. And people who tried to enter this space in terms of investing their dollars for innovation, companies are now actively turning away from the kidney care space because they feel that they can't recoup on their investments. So, what can we do? Well, we've been working on legislation. This is something that just got introduced on the Senate side, Senate Bill 2730. You can go to congress.gov and actually look this up if you want to look at the actual language within. Bills can bring together strange bedfellows. So we've got Marsha Blackburn and Cory Booker from the two sides of the aisle. It's always important when you're trying to introduce legislation to make sure you have people from both sides of the aisle supporting this. And then when you're getting co-signers on from the Senate, for example, to not just get, Democrats or not just get Republicans, but have equal numbers or, reasonable numbers. So this is to amend the Social Security Act to improve access to innovative treatment, and it's looking at two things. Basically improving the benefit to make sure that if you have forecast errors, for example, you have a 2% increase one year in payment, but there's 8% inflation, well, you're not keeping pace with things and you're not having fair reimbursement, and healthcare facilities are not going to be financially viable to support the care for this very vulnerable population. And the second of the key provisions of this bill is to really strengthen patient access to innovative treatments, devices, and technologies to establish not just temporary, but permanent add-on payments like they do have, for example, in the cardiology environment or the inpatient prospective payment system for hospitals, or also in terms of drugs and biologic products in the oncology space. So these, outdated Medicare payment policies need to be updated to reflect rising costs, to encourage use of breakthrough technologies, and to improve the lives of our patients. So this is one thing we're advocating for. And so again, this is a bill, it's not been passed yet. So, how do you change a law? I thought it would be worthwhile given that we have this out there and there are a number of other bills that have been introduced, especially on transplantation. These are the things that we can do. So we identified this problem and developed our arguments. We brought all of this, not just ASN, but the kidney care community, and we work with a group called Kidney Care Partners that does bring together dialysis organizations, big pharma, but also all the advocacy groups. And you build a coalition of support, because you know what? No one's going to pay attention to you in Congress if they say, hey, well, is the whole kidney community supportive of this? And then you work with legislators, you ask for a score. Well, how much is this going to cost? And unfortunately, this bill S2730 is not cost neutral. It's going to cost dollars. So that'll be hard to get passed, but nonetheless, got to get it out there. And then you find the sponsors like we did already on the Senate side. It has not been introduced in the House side yet. So that's what they're looking for, sponsors. You get a committee to review. It goes to the House or the Senate floor. You pass it to the other chamber and, rinse and repeat until finally both the House and the Senate come to agreement, potentially for a conference in committee as needed to get to agreement. And if you do get agreement, then you can have presidential action, and then the bill is authorized. So bills that are authorized aren't necessarily funded. And there's where you have to get your appropriations dollars, for example, from a budget that is actively being negotiated to get payment for the bill. So I thought that was interesting. So that's short-term stuff. Long-term stuff is just thinking about, I think we really do need a disruptive vision for better care for our patients. So it's not just about getting more dollars into the dialysis facility itself. How do we care better for our patients and break down the silos of care? Make sure you're thinking about slowing down progression of CKD, making sure our patients have access. You heard Josh talk about, the huge wait list. Somewhere between 12 to 14 people die every day waiting for a kidney. And, there's over 90,000 people on the wait list. Living donation is stagnant. So we have bills out there to incent living donation, even though deceased donation has been increasing. Support, just giving my plug in for transplant there. Supporting innovation and technology adoption. So we're bringing people into the kidney community, big, companies, to make sure that they understand, okay, in the future, maybe we will have mechanisms to support payment so you can actually do the R&D needed, promote patient choice and flexibility and address that organ shortage. So, let's see, there we go. Just saying a couple more things. Anything that does happen has to include the nephrologist caring for the patient. I know that sounds weird to this audience. For us, it's of course. But, some of this care could be handed off to different groups. So we need to be in the center of this. It has to include dialysis organizations if you're including dialysis as well as transplant, primary care. And, in the future, thinking about slowing progression, I love the comment. I'm not sure if it was Josh or Ben that, every talk has to say something about SGLT2 inhibitors. I didn't think I was going to say anything about them, but, if we can slow down progression, wonderful. Um, all options for the patient, making sure that they have access. And so then what can you do long terms? Well, you know what? You can actually bring attention to this. If you get things published and then bring it to the Hill staff who can bring it to their bosses, members of Congress, you will get their attention that this is something that's important. So we just published a whole series and see Jason about this. You can see the various titles, and this has actually already started to gain some traction. On top of that, you can circulate a policy brief on top of this. So this is just working on this long-term strategy. And we created a group of people, both from the regulatory as well as the legislative folks in the ASN committees that address this. Our own Dr. Matt Rivera was part of that. Thank you very much. Talking about the urgent need for PPS reform to spur innovation. And again, we've visited now, I think, 4 to 5 offices. And with our next Hill Days, we're going to really fan out over the Hill to make sure that people understand the urgency here. So, guiding principles as we're wrapping up this talk for sustainable patient-centered prospective system, quality and outcomes, really, I'm highlighting in yellow first and foremost to prioritize patient-centered outcomes. Let that person in a dialysis facility maybe never even get there, but recognize that there's some improvement over the course of a decade and a half. Survival, quality of life, functional status, and, do not ever forget any of these other items: equity and access, value, efficiency, innovation, making sure you can operationalize things and adopt these new therapies, making sure they're sustainable, and, with good data, understand how to make things transparent and engage the right stakeholders. So, working together for a better future and charting a course for a transformed payment system, the policy points that we should be advocating for, ongoing dialogue, not just with the regulatory side and Medicare, but also the policymakers up on the Hill, the legislators, and bring in the patients and the providers and the researchers to make the case. Data-driven decision making, lots of rigorous evaluation actually does matter. So, we've been worried about science this year, but when we go to the Hill and we go to the staffers, they want to know the evidence behind the comments and the assertions that we're making. They really do. And then just a commitment to continuous improvement and adaptation of the PPS, prospective payment system, to overall kidney care is really needed to meet the needs of our patients and break down those silos. So if we can implement both a strategic short-term adjustment and then pursue a longer-term vision focused on this value, equity, innovation, we can create a better, not just CMS ESRD prospective payment system, but kidney care prospective payment system that better serves our patients and promotes a good future for kidney care. So hopefully we'll get incremental and change and major disruption. So this was what we just talked about. We talked about funding and the benefit and why our patients need change, short and long-term, steps, and emphasizing the need for advocacy. I have to acknowledge all kinds of folks. Thank you so much to all of you. And I don't know I think we might have time for a minute or two for questions or comments, but for me, this is the end. And I will, Raymond may recognize this picture, but I will try to stop sharing and go from there. Okay. I think Raj, okay, has a hand up.
Yeah.
Was that your son in that orchestra?
So yes, proud mama. That is my son who won an international string quartet competition in Banff over the Labor Day weekend. And yes, that was my son. So very exciting.
Well, thank you for this thoughtful commentary and all of the work that you're doing with ASN. the one thing that bothers me about a lot of dialysis care, and maybe just say it out, last year, Javier Rodriguez made $148 million. And then we say there's not enough money for innovation to take care of our patients. $148 million is a lot of money. Then for us to say that there's not money in dialysis care seems strange.
So I could have this conversation with you all day, Dr. Marocha. And the incentives are perverse. The way that the system has developed has brought in large dialysis organizations. I didn't go into that aspect. I think about 5 years ago, I gave a ground rounds that talked about some of the perverse incentives. And you have to remember that these companies that are large dialysis organizations are for profit. And when you're dealing with for profit, this is just the reality. Their bottom line is the shareholder. And to attract somebody that can make decisions and pivot and operationalize and work on the world stage, you need to bring in a CEO. And in order to bring in a CEO, this is what it costs. And so that doesn't make any of us feel good. And this is not the dollars that are in Medicare. These are the dollars that are going to that one salary, which does not go into the facility specifically. I would posit, you could potentially make that. So that's the beginning of what I would say to that comment. But if you look at what is being spent as a result of how you get reimbursed, and we just talked about the Medicare benefit, we didn't talk about Medicaid only populations and some of the issues which are very thorny with regards to funding patients that may not have access or who may in particular not be documented, for example. That's a whole nother conversation. And then if we talk about commercial reimbursement, that's a whole nother conversation. It's expensive at the executive level, no matter where you are. And that's not going to change right now. For 2050, is it going to change? I don't know. But we do need to advocate for this. And at least by going and advocating for better mechanisms to pay for our patients, maybe we can create a system where some of the nonprofits may thrive a little bit more and not only not stay there, because the hope is that they don't consolidate and go away, but maybe can expand. And so that's how I would say that we should at least start to think about how we address this. Sorry, I will stop speaking now. I think there were a couple other hands raised as well. But thank you for the question.
Thank you so much, Suzanne. There is a question in the chat from Delar from the pediatric nephro side of things. Sorry if I missed this. With current climate, is there a discrepancy in how funding is being allocated for adult dialysis versus peds dialysis populations, or is current funding for anyone who qualifies?
Yeah, so pediatric patients qualify if you're a dependent as a child with somebody who qualifies for the benefit. So that's good. And then just very quickly, pediatric payment actually really recently increased substantially. Actually, last year it always was slightly higher. There were more needs for the pediatric population. So as in the pediatric facility, for example, you actually do get more reimbursement per patient as long as they're under a certain age. So thank you for that question. Happy to talk offline more about that. Thank you. Well, I appreciate the time. And Daniel, thank you so much for leading and everybody for joining and staying 2 or 3 minutes over. But this is an ongoing conversation that needs people who care, because that's how we fight against inappropriate use of funds and make sure that our patients are getting better care and better outcomes. Thanks.
Thank you so much, Suzanne. I really appreciate it. And thank you everyone for such wonderful talks this morning. With that, I think we can adjourn, and we'll be back again next week for Grand Rounds virtually again. Thanks, and everyone have a nice weekend.